Hi, this is Nicole Kupchik, and welcome to Back to the Basics, Caring for the Critically Ill. This is a video series in which I'm going through just kind of basics of mechanical ventilation of the patient who's failing from a pulmonary standpoint. In this video, we are going to focus on basic ventilator settings. So let's get started. What are we going to be chatting about? Well, a couple things. Basic vent settings themselves, different modes of ventilation we can use with ventilators, how we dose tidal volume. So tidal volume just being the amount of air that goes in and out of your lungs. How just different strategies we can use to improve oxygenation, how we can improve hypercapnia, and just some basic alarms. So from our last video, this is a continuation of our 42-year-old who had progressive shortness of breath for the past 2 days. Her vitals, just a reminder from the last video, her gas, so she's got a primary respiratory acidosis that's partially compensated as evidenced by her bicarb that's a bit elevated, her lactate levels a bit elevated, and from a vital sign standpoint, you can see she's pretty tachypnic and dyspneic, breathing 38 a minute, temp is 39.4, her heart rate's fast, she's hypertensive, SATs are not so great on 100% non-rebreather mask. So we got an x-ray and then quickly made a decision to intubate her based on these blood gases. So a couple other just bits of information that we'll need to know since we're going to be intubating her is that her height is 5'4" and she is 70 kilograms. So let's keep going. So what do we set on the ventilator? And I think one thing is people make this more difficult than it needs to be. So let's keep it simple for now, and we're going to build as the series goes on. But the first thing we're going to set is the mode of ventilation. Now, you might be like, well, how do I choose the mode? And here's the answer. What type of ventilator do you have? What type of mode can it provide? And what are your respiratory therapists, intensivists, your facility, what are you comfortable with? And I have to say, like, respiratory therapists are invaluable when it comes to mechanical ventilation and really guiding therapy. But the bottom line is the best mode of ventilation is the one that you know how to use in your facility and you're comfortable with, especially in a patient who you're trying to rescue. I will say most modes of ventilation are volume modes of ventilation. I'll get back to that in a second. So the next thing we're going to set is the rate, and that's literally how many times a minute do you want this ventilator to give your patient a breath? Most modes of ventilation, your patient can breathe in addition to that, but what's the minimum amount of breaths you want your patient to take per minute? Tidal volume is literally just the amount of air that goes in and out of your lungs. A good starting point ballpark is 8 mils per kilogram. So 8 mils per kilo, and that's just kind of a patient who doesn't have ARDS. If they've got ARDS, in the next video, I'm going to talk about different strategies for them. Another thing we can set is PEEP, or positive end expiratory pressure. And that's just, most patients, we give them 5, and then we'll increase the PEEP if they're having oxygenation issues. FiO2, again, you all know FiO2, but just the, fraction of inspired oxygen. In general, less is probably more in most patients. It depends on the patient, but we shouldn't be blasting everyone with 100% oxygen. You really should titrate that to a specific oxygen target. And then finally, I think the main thing you need to know is the inspiratory time, or what we call I time. So this controls how long the patient spends in inhalation. And if you have a patient, for example, like a COPDer, where you want them to drive a lot of their kind of breathing, then you might shorten the I time, especially to relieve things like auto PEEP and air trapping. But in general, an inspiratory time is set anywhere from 0.8 to 2 seconds. Some other just kind of general ventilation principles. I always kind of upset people when I say this, but ventilators are not a therapeutic. They're a support to a patient. In general, with ventilators, less is more. You don't want to over ventilate the patient. Ventilators cause harm. Ventilators can cause a lot of harm if they're not used appropriately. And I know that's like one of the things I say that's really upsetting to people, but in general, it's used as a support. If we use it incorrectly, like let's say we give too much volume in the lungs, we can overstretch the lung, and that's called a volutrauma. So in most patients, we really want to avoid kind of that over distension of the lungs. Barotrauma is when we've got extremely high pressure in the lungs, that can also cause trauma to the lungs and injury. So in general, FiO2 and PEEP are used to improve oxygenation, whereas if you've got a ventilation issue, we can use the rate to blow off excessive CO2. You can also use tidal volume, but again, you don't want to over distend the lungs. So in general, we usually will use the rate to blow off excessive CO2. So for example, let's say in our patient that we decided to intubate, we've got a pH of 722, a CO2 of 78, a PO2 of 89, a bicarb of 29, and a SAT of 85%. So in general, how do we improve oxygenation in this patient? Well, we're already on 100% FiO2, so we're probably going to use PEEP. And then how do we improve ventilation, meaning how do we get rid of this excessive CO2? Well, a strategy to do that is to increase the rate so that the patient blows off that excessive CO2. And you don't want to overventilate the patient, so it really depends on the patient's disease state as to how aggressive you'll be in fixing the blood gas. All right, so let's talk about just kind of a basic overview of ventilator modes. Most modes of ventilation that are used in hospitals are volume modes of ventilation. So basically, the ventilator is going to deliver a preset volume of air with each breath. So tidal volume just is super simple. It's just the amount of air that goes in and out of your lungs with each breath. So some examples of this would be like a sys control, AC mode, continuous mandatory ventilation, CMV mode, SIMV, which is synchronized intermittent mandatory ventilation. SIMV, I usually find we don't use a ton. When I first became a nurse a lot of years ago, we used to use SIMV a lot. I find AC and CMV are probably most commonly used, whereas SIMV, you can use if you've got a patient who's maybe breathing a bit more on their own. Now, pressure modes of ventilation. Now, you would use these if your ventilator kind of offers this mode of ventilation, but basically the ventilator will deliver a breath at a preset pressure. So once that pressure is reached, the breath will be delivered. So some different examples of this would be pressure controlled ventilation and then pressure support ventilation as well. So I want to go circle back to volume modes of ventilation. So again, AC, CMV, SIMV being examples of this. So what we're going to do is we're going to set a tidal volume. A starting point is 8 mils per kilo. Now, do I use the patient's actual weight or their predicted body weight? And the answer is their predicted body weight. Because if I gain 50 pounds, does my lung size change? And the answer is no, your lung size doesn't change. So you want to use their predicted body weight. I'm going to show you some charts that we commonly use to dose tidal volume. Now, in volume modes of ventilation, the patient can assist. So especially for example, like assist control, the patient can assist, but the ventilator will always deliver that set tidal volume. So the patient can alter their rate and pattern, but not the volume. So they will always get that volume. And the nice thing about volume modes of ventilation is it can really reduce the workload of breathing. Now you want to set a rate. So the rate is basically just a minimum breath rate that you want that patient to get. So let's say we choose 12. So that means is it 5 seconds? Am I doing my math right? So every 5 seconds, your patient will get a breath. But if they want to breathe over that, they can, which is it's really easy thing for the patient to do. All right, so now these are the famous charts that we use. These are called the predicted body weight charts. And these were introduced back, I was actually at the hospital that was studying this in the late 90s, early 2000s when we were doing the ARDSNet trials. So I was really lucky to work at one of the hospitals that did the study. But what you do, the way you use these charts is male, female. So I've got female on the left over here, male on the right, and you need to know the patient's height. So for example, our patient was 5'4". So what we're going to do is we're going to go to the section where it says 5'4", and you're going to look at their predicted body weight. So 5'4", their predicted body weight would be 54.7 kilos. And if we want to start at 8 cc's per kilo, we would set her tidal volume at 438. If we wanted to go down to 7, it would be 383, 6 6 cc's per kilo would be 328. So just to kind of give you an idea, these are very commonly used charts that are used to dose tidal volume. So let's get back to our patient. So again, they had a partially compensated respiratory acidosis. So we decided to go in AC mode, assist control mode, because that's the mode that our ventilator uses. We decided to start at 8 cc's per kilo, but her x-ray was looking a little ardsy. So then in my next video, I'm going to chat about ARDS, but we're going to start at 8 cc's per kilo, probably going to be working our way down to 6 cc's per kilo. We chose a rate of 16. So how do you choose the rate? And here's how you choose it. You look at your gas and you go, and you guess, right? You guess. I don't know. She had a really high PaCO2. What was it, in the 70s? So we're going to set her rate a little bit higher to blow off some of that excessive CO2. We decided to go a little more than 5 of PEEP because her x-ray was looking a bit ardsy. She had bilateral pulmonary infiltrates, which were non-cardiogenic. So we want to use positive pressure to distend and open up those airways, and she was already on 100% non-rebreather mask, so we just decided to start at 100% oxygen. So we get her on the settings, let her kind of settle down for about 30 minutes, and repeated her gas. So here's her repeat gas. So 728, so she's still acidotic, 66, 104, 28, and 89%. So given that gas, what improvements can we make? Well, anytime you look at your PO2, you want to look at it in relationship to your FiO2. So her PO2 is 104, but it's taking 100% oxygen to get her there. So that's really not good. And that's what we call the P to F ratio. In the next video, I'm going to chat about that quite a bit more. So her P to F ratio is 104, which isn't very good. Normal is over 300. So that's not good. So we need to improve her oxygenation, and we've got room to increase the PEEP. So we could try that. And then she's got a respiratory acidosis. So how do I get rid of this CO2? I can consider increasing the rate. So the other thing is her x-ray was looking a bit ardsy. So in ARDS, and again, the next video I'm going to chat about this, we want to get that tidal volume down. So she's at 8 now, but we're going to work on getting that tidal volume down to about 6 cc's per kilo, which is considered lung protective. So we don't want to overinflate her lungs, and so we'll work to get there. We're going to increase her rate to 18. Again, we're at 16. Let's bump it up to 18, blow off a little bit of that CO2, and then let's increase her PEEP to 10. And again, all of this is just kind of a guessing game. You set, reassess your patient, adjust, and you kind of keep going back and forth in that fashion. Okay, so we changed her vent settings to what we just discussed. So she's on an assist control mode. So it's a volume mode of ventilation. We got her slowly down to 6 cc's per kilo. She's tolerating it okay. Her rate is 18, her PEEP is 10, and her FiO2 is still at 100%. So we repeat her gas 45 minutes later, and here's her new gas. 7.3, 62, 108, 28, and 90% sat. So, what do we do about this? Well, I don't know, a couple thoughts. I think we could consider increasing the PEEP, especially given her x-ray. We might play with this a little bit, go up on her PEEP to kind of open those alveoli, and then maybe back off her FiO2 a little bit. So we can kind of try, see how she tolerates that. We can possibly increase her set rate on her ventilator. Someone like this, I don't know, in ARDS especially, we don't shoot for a perfect blood gas. We shoot for good enough, right? So, I don't like her being this acidotic. I mean, I've seen much worse, trust me, but, maybe we can increase her rate a little bit, blow off a little bit more of that CO2, and just see how she responds. And then based on her x-ray, we definitely should be having the discussion about ARDS, and if she doesn't turn around, talking about some rescue strategies like proning, for example. So anyway, these are just some kind of basics on ventilator settings. Now, some basic alarms I just want to review really quick. If you get a low pressure alarm on your ventilator, that's usually a leak or disconnect in the circuit. So anytime you get an alarm, I just want to say always look at your patient first. Look at them first. See, are they comfortable? Are they struggling? And then I always start with the patient and move my way to the ventilator. So check all your connections. Make sure everything's connected. High pressure alarm usually means there's high pressure in the circuit. A lot of the times, this is caused from secretions, maybe water in your tubing or kinks in the tubing can also cause high pressure. And then finally, the other big alarm you should be aware of is like a low minute ventilation alarm. So minute ventilation is just the amount of air that you move in and out of your lungs per minute, and it's very similar to a low pressure alarm in that you should look at your patient, see if there's any a leak or any disconnects in the circuit, and then go from there. So I want to thank you for joining me in this video. Again, it was just meant to be a super quick, down and dirty on just ventilator settings. This is the second video in this series. In the next video, I'm going to be talking about lung protective ventilation for ARDS and discussing some rescue strategies as well. And then again, I'm going to continue in this series talking about what are all the numbers that we measure in ARDS, how and why does proning work, arterial lines, and then vasopressors, inotropes, and vasodilators. Oh my! So anyway, so again, thank you for joining me in this video.